Are you a patient or even a clinician waiting to complete a musculoskeletal assessment? Keep watching to find out what you need for a subjective assessment. So, the subjective assessment is the collection of all vital information that's required for diagnosing accurately and managing any injury or condition. It also helps identify the patient's general health and any medical conditions that may affect the recovery and management of their injury or condition. So, whether you're a patient or a practicing clinician or a student, grab a pen and paper to write down the questions to create your own little template. So, from the top, I always ask, where is the pain? Use this as an opportunity to mark, even with a marker, exactly where the pain is. This again helps with the accuracy of your diagnosis. Then you can go on to how it happened. Was it specific or insidious or a gradual onset? If it was specific, use this opportunity to demonstrate the mechanism of injury. If, as a clinician, you get the patient to reenact their injury, you can then see the structures that may have been affected. And as a patient, it can help create a clearer picture of what may be going on. When going further into the mechanism of injury, consider whether there was bruising, a click or a pop, giving way, instant swelling or swelling that came on over the day. And if the patient, for example, was in the middle of a football game, were they able to continue that game or did they have to get carried off the pitch? If the onset was gradual, the rest of the assessment can help identify a more accurate diagnosis. At this time, you can also ask about the progression of the pain. Has it gotten better? Is it worse? Or is it exactly the same? As a patient, you may identify previous treatments or things that you've been doing at home that may have helped your injury, all of which help the clinician identify a more accurate diagnosis and identify more effective management. You can then go on to when it happened. How long have they had the injury? Have they had it before? And how long did it take to recover? In identifying when the injury occurred, try to be exact and specific. Don't stick to vague answers like, a while ago, maybe 2 years ago. And now we move on to what type of pain it is. Here are a few examples. If it's associated with bone, patients usually say a deep, nagging, dull ache. They can sometimes refer to it as a toothache, and then if it's muscular, again, they can describe it as a dull ache. If it's nerve root, they'll say sharp, shooting, electric shock pain. And if it's to do with the sympathetic nervous system, burning, a pressure or stinging. And lastly, vascular is usually described as a throbbing, diffused pain. And then we have the AGs and the eases. Knowing easing factors can be important when devising a self-management plan or even the management within the clinic. And then we can go on to severity. Do they feel the pain is mild, moderate or severe? Here we can use a functionality scale. And next, irritability. How easily are their symptoms brought on? In irritability, we can also consider intensity of pain. This is where we usually use the visual analog scale. The VAS scale is used to determine the level of pain, 0 being no pain whatsoever, and 10 being call an ambulance. Usually the VAS is not consistent throughout the day. We can then ask the VAS when the symptoms are settled and when they are irritated. Okay, next, to identify the nature of pain. We can use previous findings from any previous MRIs, AMRIs, X-rays or any other scans or physical assessments. Now the next subheading, 24-hour pattern. Do the symptoms have a pattern or are they more activity dependent? Some patients may say they feel more achy and like an ironing board in the morning, whereas others may say it's not too bad after they've just woken up, but as they progress through the day and towards the evening, they're falling to bits. Now, for one of the most important parts of the subjective assessment, the red flags. These help identify if there is possibly something more malicious or severe underlying. The questions we usually ask for red flags are, do you get night sweats? Is there constant pain at night that's unremittent no matter what position you're in? Sudden, unexpected weight loss, fever. Does the patient look very unwell? And then a loss of appetite. And lastly, a previous history of cancer, either in the affected area or anywhere within the body. An extra red flag would be thoracic pain, random thoracic pain. We're not talking about the kind of ache you can get from prolonged poor postures or from a direct traumatic event such as being dropped on your back in martial arts. Random thoracic pain that's unremittent may need further investigation. And then we have more special questions. There are more special questions for each specific joint. However, in this video, I'll cover the special questions for the lumbar spine and the cervical spine. So, to start with the lumbar spine, we want to identify if there are any cauda equina symptoms. Cauda equina is Latin for horse's tail. This is where the one body of the spinal cord splits into several nerve roots. The level at which it splits is usually from L2, the second lumbar vertebrae. This area is also known as the conus medullaris. Now, the cauda equina symptoms are: do you have any bladder or bowel dysfunctions? Bladder being retention. You need to go for number 1, but nothing comes out. And bowel being incontinence. You don't even know you need to go for number 2 and it's there. Then bilateral neural symptoms down both legs, pins and needles, numbness or tingling. This is also usually constant. And then thirdly, saddle anesthesia. This is abnormal sensation or numbness around the inner thighs, around the bottom and then the genitalia area. And then gait deviations. Are you tripping over your own feet when walking or possibly have a drop foot? Drop foot is where you're physically not able to lift your toes to clear them when walking. And then lastly, unremitting pain. Again, no matter what position you're in, the pain does not go. And now the cervical spine. We usually refer to the 5 Ds and the 2 Ns. Dizziness is the severe dizziness that's constant, random, and not associated to a drop in blood pressure when they stand up quickly. Diplopia, double vision. Dysarthria, physically finding it hard to articulate their words. Dysphagia with a G, trouble swallowing. And drop attacks, the feeling of fainting or actually fainting. And the 2 Ns, nystagmus, rapid eye movement, usually left to right, and numbness, usually constant numbness down the arms into the hands and into the jaw or the mouth. Any of those symptoms can usually indicate if there is a problem with the spinal cord within the cervical spine or a compromise in the blood circulation to the head or the brain. Now, once we have enough about the injury itself and cleared any red flags, we can move on to medications. For patients, bringing in a prescription list or a written list is usually quite helpful. It helps clinicians spell all those really awkward medication names and it prevents us from missing out any vital medications. With medication, also ask if they are taking any anticoagulants. These are medications used to help thinnen the blood and can compromise its ability to clot. In this situation, we need the INR, International Normalized Ratio. This helps indicate the blood's ability for it to clot. Values between 2 and 4 are seen as normal. The higher the number, the thinner the blood and lower the ability of clotting. As a patient, usually when taking anticoagulants such as warfarin, you may be given a small booklet. If this is the case, please bring it along to the assessment. If the INR number is not present in the assessment, it is very important you either contact the GP there and then, or the patient is aware they need the INR number before the next session. Now, if the INR number is too high or abnormal for the patient, treatment is usually contraindicated. And then we can go on to past medical history. The acronym we usually use here is THREADOOS. T meaning thyroid, H meaning heart problems. This can include blood pressure. R meaning rheumatoid arthritis. E, epilepsy. A, asthma. Asthma, it's important to know if they're taking inhalers. Some inhalers are steroid based, and if used daily, they can compromise bone density. Therefore, caution is required when treating. And then D meaning diabetes, type 1 or 2. The first O, usually I call it oncology, the history of cancer or even present cancer. The second O, osteopenia or osteoporosis, brittle bones. The first S, Surgery, so surgery that is relevant to the area. And the last S being steroids, so the type of steroids that are used for anti-inflammatory purposes. As mentioned with asthma, they can again lower bone density. And finally, we can wrap up this subjective assessment with the patient's social history, hobbies, and beliefs. We can start with occupation. Are you working? Has the injury caused time off work? And what is the job? Hobbies? Are you still able to do everything? And what are the hobbies? Are they more physical? Are they more sedimentary? And do they perhaps need adapting? And finally, dependence. Kids, no kids, full-time carer for their spouse, parent or kids. This again will help us set more realistic goals and help identify why the injury or condition may have occurred. Now, one of the things I like to do is ask the patient what do they think is going on and ask their expectations of me. The mental attitudes and beliefs of a patient can significantly impact on their recovery. Asking a patient their goals and what they expect can help the clinician provide more realistic goals that may match those of the patient and help manage the expectations from treatment. So when setting goals, consider making them SMART: specific, measurable, achievable, relevant, and time-bound. So when it comes to Mr. Joe Bloggs, the 72-year-old with severe arthritis in his hip, we're not expecting him to get 100% better and then return to playing basketball at the park. Okay, so that just about wraps up a succinct but detailed assessment that I feel will help collect all relevant and important information. If you found this video useful, give it a thumbs up and subscribe. Best of luck, and I'll see you in the next one.